There we go. So I'm Carmen Masson, and I'm a faculty member at the University of California, San Francisco, Department of Psychiatry and Behavioral Sciences. You can go back one slide, please. The I-STARR project is co-led by Drs. Amy Miracle and me at the and Amy, who's at the Public Health Institute. And the team also includes co-investigators Sarah Zemore, Lenny Jason, Mina Subbaraman, Libo Lee, and our project coordinator, Quinoja Capitini, and our communications specialist, Diane Schmidt. Next slide, please. So we're also very fortunate to have with our project activities that are guided by our 17-member advisory board, which is comprised of a diverse group of leaders from across the country. And our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, and researchers and educators. Next slide, please. So let me tell you a little bit about our presenter who will be presenting today, Dr. Aditi Tarfa. Dr. Tarfa is a postdoctoral associate at the Yale School of Medicine. She earned her PhD in health services research from the University of Wisconsin-Madison and a doctor of pharmacy from Drake University in Iowa. Dr. Tarfa's research focuses on improving access and the delivery of pharmacy services for under-resourced communities. Today, she is presenting work from her pilot study through the Infrastructure for Studying Treatment and Addiction Recovery Residences, or our project, the I-STARR project. So this webinar presents findings from a mixed method study exploring awareness of and experiences with recovery housing among mobile pharmacy patients with opioid use disorder and community pharmacists. So without further delay, let's turn the presentation over to Dr. Aditi Tarfa to get things started on the topic of expanding the impact of pharmacy services by integrating them with recovery housing.
Awesome. Thank you for the introduction, and really excited to have everyone here and to be talking about this pilot project. So first, I do not have any conflict on competing interests to declare. However, this work is first supported by the National Institute on Drug Abuse, NIDA, to my postdoc primary mentor, Dr. Sandra Springer. And then this sub-study that I'm presenting is a pilot award from the I-STARR infrastructure that we just shared about. And so for our outline, I will be reviewing in general what recovery housing is, what pharmacists are doing on access to medication for opioid use, and then the mobile pharmacy and clinic intervention. And then I'll go over the methods of the study results and our exciting next steps. All right, first, so what is recovery housing? So according to the Substance Abuse and Mental Health Services Administration, SAMHSA, recovery housing is a recovery support service that was designed or initially designed by persons in recovery for those that are initiating or engaging and sustaining recovery from substance use. And this includes opioid use disorder, which is what I focus on for this presentation. And I want to highlight this key part of it, that it's designed initially by people, persons in recovery. So it's a pure belt system. And then for people with opioid use disorder and other substances, recovery housing is part of their recovery process, but most especially it includes treatment, overdose prevention, and just entire overall recovery. And so we have recovery houses that are able to provide some support for harm reduction. We also have those that are able to help with treatment, and we'll talk more about that. And then we have also just that continuous recovery support and being part of a recovery community. All right, so research gap. So medications for opioid use disorder, I'm talking about buprenorphine, methadone, and naltrexone, are the only treatment that are proven to reduce overall mortality for people with opioid use disorder. And then recovery housing can provide support for medication for opioid use. However, the policies in recovery housing do vary widely. And many recovery housing settings actually restrict, discourage, or fail to support medication for opioid use disorder, which I will call MOUD for the rest of this presentation. So we know that recovery houses restrict, discourage, or fail to support MOUD initiation or continuation. And so just in the US context, we know that there are over 9.4 million people that need treatment for opioid use disorder. And then only 25% of those individuals have actually received MOUD. And then there are over 10,000 recovery houses in the United States. And so if we do a quick math, we see that there's an opportunity for recovery housing to provide support for this 25% that have not received medication for opioid use disorder, or some that have received but need continued support. And then this is where pharmacists come in. A pharmacist, I do have positive bias related to pharmacy practice. But one of the data that we talk about in pharmacy research is that 90% of Americans or people in the US live within 5 miles of community pharmacy. And so this is your retail pharmacies that are in community. So that's considered one of the most accessible healthcare setting. And then we know that pharmacists dispense and manage medication for opioid use, specifically buprenorphine and naltrexone. And then pharmacists are actually just one of the few healthcare professionals who can see MOUD treatment over time. So community pharmacists have data on when a person starts their treatment, what dose they're on, when they're lost to follow up, when they re-engage in treatment over the course of their life. And so we have that in pharmacy data. And we know that for a lot of our MOUD studies on the national level, pharmacy dispensing data was used as the main source for actually tracking access to medication for opioid use. And then, so as that, pharmacists were able to identify gaps in access, were able to see when there are missed refills, when there are insurance issues, when there are treatment interruptions. So we have a really full picture in access to medication for opioid use disorder. And then in some states, specifically 10 states in the United States, pharmacists are actually able to prescribe and manage medication for opioid use disorder. So there's a huge role that pharmacists can play in medication access. However, despite we knowing that medication for opioid use disorder is the standard, there's a break of that into recovery housing, and then even very little research on how recovery housing residents, so those who live in recovery houses, actually perceive access or what their preference is for medication for opioid use disorder. And then when it comes to recovery housing research, over the last 40 years, there's only been, I think, 135 research studies that have actually empirically looked at recovery housing. And then only 5 are actually related to medication for opioid use disorder and recovery housing. And in the science field, that's very, very little. And so we know about people with opioid use disorder. We know about recovery housing, but a little bit about recovery housing, but even less about medication for opioid use. And so I started, I think 2 years ago, thinking, how do people in recovery housing access medication for opioid use? So we know that there's this big gap. Where do they get their medication? And so this is actually a screenshot of a Google search that I did last year, where I was looking at pharmacy and recovery housing. And then Google was asked me if I meant drug-free, so drug-free recovery housing, because it was not associating recovery housing and pharmacy. And so we see that just like a quick Google engine search, because these are uncommon parents, it was recommending that I look at drug-free. And this also, for a lot of our recovery housing experts here, they're aware that in fact medication for opioids in some houses are discouraged, hence drug-free. And then, so is there a role for pharmacists then in this landscape that even Google has helped us identify that there's no commonality? So one thing that we're thinking about is perhaps community pharmacists that are regularly seeing our patients that are receiving medication for opioid use, or even in those states where they're the people initiating and maintaining treatment, maybe there's an opportunity for pharmacists to connect people to recovery housing. And then they can also share information or referrals to recovery houses in their communities. And then could they also help recovery housing support MOUD? That's another question. So I talked to a few recovery operators in Connecticut. So those are people that have recovery houses in the state of Connecticut. And I asked them about their relationship with pharmacists, and they told me, well, actually, we have had, a pharmacist come to the house and do some naloxone education to our recovery housing residents. We also partner with pharmacists to help manage medications for our recovery housing residents. But as I've shown you, when we go back to the literature, none of this is captured. So my study actually aims to understand recovery housing access amongst individuals with opioid use disorder that are accessing a pharmacy service. And then I want to identify MOUD access barriers and facilitators in recovery housing. And then I also want to explore the opportunity for pharmacy facilitated MOUD access in recovery housing. And this is done via a novel mobile pharmacy and clinic intervention. And I'll share more about that. All right, so this study is a convergent mixed methods design, and I will just highlight this to show you. So I have a quantitative and a qualitative data collection processes that are happening concurrently. So first, I have patients that are over 18 years of age, have a history of opioid use disorder, and this is captured through a rapid opioid use disorder assessment scale, through our mobile pharmacy and clinic prescription data, and then through our engagement with our mobile pharmacy. And then I did a survey of these individuals, and then I'll show the data analysis and the findings. And to incentivize their participation, I gave them a $25 gift card. And then for pharmacists, I interviewed pharmacists that are licensed to practice in Connecticut, but specifically that they practice in a community retail setting. And this was done through semi-structured interviews. And for the data analysis, I used conventional content analysis process, and to incentivize pharmacists for their time, I provided a $50 gift card. Okay, and so the setting is, this study is done in urban cities in Connecticut, USA. And the main question is, why Connecticut? So Connecticut in recovery housing availability ranks 23rd across 50 states. So there's nothing really special going on in its housing availability. However, we see that a majority of the recovery houses are located in urban counties that actually need the support. And then MOUD in recovery housing in the state of Connecticut is not guaranteed or standardized at a state level. So this is an open field for us to actually learn more about what we can do, and maybe perhaps there are some policies that we can introduce in a state level that would support medication for opioid use integration. And then lastly, where this study is said is that this is where mobile retail pharmacies are legal. So I'll talk next about the intervention, but mobile pharmacies were designed to reach people who use drugs, including people with opioid use disorder specifically. So Connecticut has, the housing availability, but also an intervention where pharmacies are brought to people in their community. All right. So the mobile pharmacy and clinic was legalized in July 2023. It's called the Integrated Mobile Opioid Treatment and Infectious Disease Coordinated Care in Your Neighborhood. And it's a 38-foot van. I have it there. The funding was provided through the National Institute on Drug Abuse to my postdoctoral mentor, Dr. And so it's a licensed and regulated pharmacy that operates from a movable vehicle. And it's the first, again, in the country, and I think in the world too. So this is how the mobile pharmacy operates. So, right, we have the mobile pharmacy go into shelters, encampment, and other underserved neighborhood in Connecticut. And within that, we have a pharmacy. So at the back of the vehicle, we have a pharmacy and a pharmacist. And so we have a full formulary, over 400 medications. We do not have controlled substances on board, but we've partnered with a stationary pharmacy that's able to provide us our MOED. And then the pharmacist is, of course, able to provide overdose education, and then also prescribe and distribute naloxone. And then we have a clinic space too. So at the other end of the vehicle is a clinic space, and we have a clinician and a nurse practitioner. They provide all sort of primary care for all conditions, and they're also able to initiate long-acting injectable buprenorphine, so one of our medication for opioid use. They also provide some of our medications for our infectious diseases that we're interested in, so HIV and Hep C. And then they're also able to see individuals either in person or over telehealth. And then lastly, we have community health workers that actually go into the community with our mobile pharmacy. They're able to screen for substance use disorder, including opioid use disorder. They're also able to check for blood glucose, blood sugar, provide testing for the infectious diseases that we're interested in. And then they're also able to link social services. Then they link clinicians to the patients either through telehealth or in person with our clinician on board. And so we have our community health worker go into the community and screen, and I think for diabetes there. So the main picture is a mobilized pharmacy with a clinic space that actually goes into communities and area of needs. And so what we're trying to explore is where are we going and what are we seeing? And so since we started this in December 2023, we've seen over 1,000 people. So we've provided care, a majority women, Hispanic, 27% of our population are unhoused or unstably housed because we go into the community, we're able to meet that population. And then less than half are also uninsured. And then for medication, the pharmacy piece, we provided over 3,000 prescriptions since the last 2 years been in operation. And 117 are for substance use disorder, and 48% of those medications are for opioid use disorder. And then in general, we've actually provided screening for 360 people for opioid use disorder, and 104 of those individuals that have used our mobile pharmacy were eligible for this study. Okay, so I'm going to present the first findings. So our survey of individuals with opioid use disorder that are receiving care at our mobile pharmacy and clinic. So the number of individuals that I screened and surveyed were 48. 57% are women, and 90% are Medicaid. And then we also have that all of them are leave in Connecticut. And then so for housing status and their MOUD status, 41% of our individuals were homeless or have no fixed housing. And then for medication for opioid use, we have that about 10% of them are on sublingual buprenorphine, and then 39 are on methadone, 39%. And then we also have a 26% that are currently not on any medication for opioid use. So again, these are individuals, 49 individuals that are currently in the last 6 months have no fixed housing. About 39% are on methadone, some are on buprenorphine, but also 26% are not currently on any medication for opioid use. And so the survey topics that I kind of explored with them is their experience recovery in general, what are their thoughts, perceptions, and then how did they, if at all, access medication for opioid use while in recovery housing? Did they want to have access if they did not have access? And then their willingness to consider recovery housing in the future, and then their likelihood of using a pharmacy-based intervention like the mobile pharmacy while in recovery housing to get access to medication. And so because there's no literature on this, I had to ask some of the first questions is just, what is your experience with recovery housing? And then how did you access medication for opioid use? And so their recovery housing experiences. For the 49 individuals that I surveyed, 79% of them have lived in recovery housing at any point in their lifetime. And then when I looked at types of recovery housing, majority of them lived in sober living facilities. And this is recovery housing that has some level of monitoring, but it's also might have some staff and is peer-led as well. And then for their duration in recovery housing, most participants lived for 1 to 3 months, and then the other half have lived in for 1 year or longer in a recovery housing. And then secondly, well, how did they access, if at all, medication for opioid use in recovery housing? 74% of the individuals, so out of 27 that said they did access medication for opioid use, 74% of them did want access, and then 82 wanted access, but that also includes people that wanted but did not have access. And so I wanted to know, well, if you accessed or had a desire to access medication for opioid use, how does that happen in the recovery housing setting? And so there were several answers to this, and most of them fell under either was self-pickup. So in the recovery housing that they were at, they went to get their own medication. They had transportation support. So someone dropped them off to go to some place like a methadone clinic, or they had staff in-house. And I just had some example of the open-ended questions. So for self-pickup, people went to the clinic, they by themselves and had access to medication. And then for some, the recovery housing resident actually gave them rides in a van to go to pharmacists to pick up medication. And then for some of the recovery houses, we had people that had a doctor on call in the house that was able to provide them medication. And then others also had nurses that distributed medicines within their house. And then for those who did not have access to MOED, what were some barriers? So one of the first one, and I'm sure will not be a surprise to some of our recovery housing operators, is recovery housing policies. And so these are some of the open-ended quotes, and I'll just share it. So for one of the participants, they shared that because there are rules, they do not want people to get on medication, so MOUD, and be in the house. And so they could not be on medication for opioid use while in the house. Similarly, for some participants, if they said if they use substances, they were actually kicked out of the house, and then they lost access to medication as well. And then for some also, they had these experiences where they were threatened to be taken off medications, and they were also not given access to similar treatments. And so they also did not get a choice in saying what medications they could get. And then I think when I wrote stigma, I also think that all the examples that I shared just right now, it's not just about policy, but about stigma. But some specific example of stigma is for one participant, if you're already on Suboxone, so the recovery houses may not take you. You have to stop your medication for opioid use and then get into treatment. And another person said you could only get on medication if you had a dirty urine, and in code, because that meant that if people were already using substances or their opioids, or if they relapsed, so went back to substance use. But if you did that, then you would have to go back to jail. And so this is all really housed between just policies, but overarching is stigma about medication for opioid use. And then next, we asked about willingness to go to treatment to go to a recovery housing in this very moment. So they had varying experiences. Some had access to medication, some did not. And a majority were just in this moment, would you be open to the idea of recovery housing? And we had about 75% express at least some sort of willingness, and then even 57%. And then I asked, well, what would your reason to re-engage in recovery housing be? And I have a lot to share about this that would not come as a surprise to people, but stability and structure, because then you would have structure to go to recovery meetings and recovery housing. And then people had personal motivation, desire to stay clean, and I have that in quote, because they believe that it's a healthy choice to make. And then safety and basic needs. For our participants, especially if you remember, majority did not have stable housing at the moment, so not having stable location. This person has been homeless since they were 16, and they actually want to go to a recovery home just to have those needs addressed. And then one shared about having disability and has to wait in shelter, having no access to their basic needs, even accessible bathrooms, and going to recovery housing that's tailored to their need is a reason that in this moment they would be willing to go to one. And then reason not to go into one at the moment, knowledge about access came up. So they do not know or have information available in peer meetings about where would you go to if you're interested in going to recovery housing. And then policies is a huge one. For people I think I shared earlier on that 6% had been in a jail or just involved with the criminal legal system in the last 6 months. And so for some people, they say, after going through that system, you're not offered recovery housing as the first option. And then barrier 3 is what we've talked about previously, and that's access to medication and medication-related stigma. If you're on methadone, then you cannot go into recovery housing. And then because there's judgment about methadone, so for 39% that are on methadone. And then some recovery housing do not accept Suboxone or medication for opioid use, and this person has had personal experience, so they'll rather be in the community and be taking their medication for opioid use. And then I asked, so our digital mobile pharmacy intervention is going into communities. If we partnered with recovery housing, will this be a pathway for access for medication for opioid use? Will you be willing to use our mobile pharmacy in a recovery housing in that capacity? And it's a loaded question, but having used the mobile pharmacy themselves, they're aware of the services. So this not only includes medication, but we're also able to provide our community health workers that provide social support, our clinician that can see them for primary care, and then our pharmacy that can provide access to them for medication for opioid use. And so 37 individuals said yes, and then we had a few that said no here. And I will go into why they're not interested at this moment. And so their reason, again, is going back to that rules about restricting medication for opioid use, initiation, or use. Their preference to avoid medication entirely. So we had the 20% of individuals that are not interested in medication for opioid use. or some that actually just did not perceive a need. So even if the pharmacy brought medications, they're just not interested. And then for those that were interested in using the mobile pharmacy, what is their reason? And majority is about convenience and easy access. And so because the mobile pharmacy goes into their community, um, they're able to access them. And then the mobile pharmacy removes this transportation barriers because we have seen that some of our inmates in the recovery housing had someone take them to a methadone clinic to get their prescription. So having the mobile pharmacy take away that transportation barrier was important for them. And then for some, it's that reliable access to medication. All right. And so other things that they talked about was privacy, discretion, and disability accessibility. The mobile pharmacy for one of our patients that talks about disability is able to provide care to them and in discreet fashion. And they said the mobile pharmacy coming to them is more personal. And then they have trust in the mobile pharmacy team. That has been a huge one because the mobile pharmacy is going into the community. And so, they can rely on someone to pick up the phone. We have our community health workers that are always reachable to our participants. And then they talked about just more personal and listen. And even when I was talking to, when I was surveying the individuals, they had a slight frustration about this because it was more reason not to than reason to, because we're coming to them. They believe the care that they're receiving is personal and that's important to them. And then reliability for treatment is another one. It's guaranteed to be there and dependable. They have not missed their medication in the past because they had a history of missing their medication, but the mobile pharmacy brings it to them. And so they're less worried about that. And then because appointments are hard, so they talked about even if your recovery housing is taking to a methadone clinic, you actually do not have appointments there. But the mobile pharmacy comes in and it comes and has that availability for you to be seen by our clinicians. All right, so for a summary of our survey findings, I want to start by who we spoke to again, just to add more context or reorient us to where we are. We spoke to 49 adults with opioid use disorder that are living in Connecticut. They're using a mobile pharmacy and clinic, the only one that's first in the country and legalized in the state of Connecticut. And majority of our participants were women and most on Medicaid, and then 41% of them are unhoused. And what are their experiences with recovery housing? 80% had previously lived in recovery housing. 75% expressed some willingness to use recovery housing now, while 57% were highly interested in going into recovery housing. And then in their recovery housing experiences, for those that had lived in recovery housing, 74% had access to medication for opioid use. And then 82 would have wanted to have access. All right, and so what they want is really reliable, stigma-free access to medication for opioid use, and then integration for medication support, so mobile pharmacy into their recovery housing. And then 71% are likely to use the mobile pharmacy in this capacity if it were to provide care in a recovery house. All right, so I will pause here and go into part 2. And because this is a convergent mixed methods design, I was talking to both the pharmacists. So I was interviewing the pharmacists and surveying the individuals at the same time. All right, so I interviewed 14 pharmacists. Majority of them, 57, were Asian. For about 28% of them were managers or owners of pharmacies in Connecticut. And also like a good percentage of them, over 60%, have had work in this community pharmacy setting for 1 to 6 years. All right, so the first theme, because this was qualitative interview, was that I found that pharmacists had limited training or awareness of recovery housing. So I asked them, what's recovery housing to you? How would you describe it in your own words? And so one of the participants said, from my pharmacist perspective, we really have no training in recovery housing. We never went through this in schools. And then one pharmacist was saying, because they had no idea of what recovery housing is, they'll be interested in touring, meeting with clinicians so that they as pharmacists can understand who they're helping. And then second, we also see that pharmacists do support patients in accessing medication for opioid use, and they're interested in that. So they provided their real world support one pharmacist said, since we pharmacists are the most accessible, we see patients in their most vulnerable states. We're first in line. And this pharmacist particularly was saying they had never actually referred someone to recovery housing, but actually they can see when their patients are in need of this support and they can help with that. And then next, pharmacists had this positive perception of our mobile pharmacy. Pharmacists view the mobile pharmacy as an important innovation, novel for trust building and removing barriers to people in recovery housing. And so this pharmacist was talking about the mobile pharmacy, and they said, because it gets into the neighborhood, I think that opens better communication, more one-on-one rapport building with the pharmacist. Right? And then next, the perception of the mobile pharmacy as a point of care for initiation and coordination. So because there's only one mobile pharmacy in the US and also still in the state of Connecticut, we explored how can the mobile pharmacy partner with these community pharmacists. So they envisioned a perceived share care model where the mobile pharmacy can initiate or stabilize treatment while our typical brick and mortar pharmacies can continue medication for opioid use long term. So they see the mobile pharmacy as something that can provide acute care, while the stationary brick and mortar pharmacies can see patients long term, even after they leave recovery housing. This pharmacist in particular shared about patients leaving recovery housing, they come back to the pharmacy, they come back to the community, and that's where they receive their care. And then another pharmacist shared that mobile pharmacists will be the one that gets the ball rolling. You get the whole regimen set up, and then the patient can continue at a local pharmacy. And then lastly, this came out later on because when I asked about recovery housing, and this is just in qualitative interview practices, I asked about recovery housing, what their perception is. And that's where that first theme came up, where people said, well, I actually don't know what that is. And then later on, when we were talking almost organically, then pharmacists started telling me how they partner and what they do with recovery housing, similar to how recovery housing residents have shared with us. So pharmacists shared that they actually do medication packaging and dispensing at nearby recovery housing. Some pharmacists have been invited on site to recovery housing staff about drugs and their effects on their body. This pharmacist actually shared having done this for several years in the past, where they come in and tell the recovery housing staff about what drugs are and how the effects they have on the body, so that the recovery housing staff can better support their recovery housing residents. And then another pharmacist and also our recovery housing operators have shared about pharmacists coming in and providing overdose education to both staff and residents. And then some pharmacists said, because they're in close proximity to recovery housing, they've actually received calls from recovery housing staff on medication-related questions. And then we had a pharmacist that shared this interesting history with recovery housing, where because they were a pharmacy owner, they had a pharmacy close to recovery housing, and they said they invited the recovery housing staff to bring any substances that they might have found on their residents to know what is in it. So they were able to provide toxicology report on some of the medications. They were able to check and see what medications a recovery housing resident had, if the recovery housing staff needed that information. And then, so in summary, we know that there's this limited didactic awareness or training from the pharmacists on what recovery housing is. But pharmacists also see themselves as medication for opioid use access points. So when they shared about what they envision for how mobile pharmacists can support, they see that they can help with initiating, and then our stationary brick and mortar pharmacies can help with continuous maintenance for medication. And then for our mobile pharmacy and clinical intervention, they had a positive perception of it as an intervention to help access medication for opioid use in recovery houses. And then lastly, the theme that I went back to find after having spoken to individuals was pharmacists actually do already interact with recovery housing. So when Google says, drug-free pharmacy, no connection, there actually is connection in the community. We just haven't explored it fully and reported it. And because this is a mixed method study, I have a matrix that actually integrates what we found from both the patients and the pharmacists. And this is what this overwhelming table is about. But I wanted to focus on a few things. So for the knowledge of recovery housing, if we do recall, our patients said that they had limited understanding of where to access recovery housing. And so there's this knowledge about recovery housing. And so we see convergent also between the patients and the pharmacists on what recovery housing is. And then for access to MOUD and stigma and policies, there is a connection where, they both describe access, but because pharmacists did not share knowledge on knowing what even happens in recovery housing, our pharmacists said they actually want to start visiting recovery housing to know what care is provided in recovery housing. We only know what access to MOUD and stigma and policies are from the patients and not the pharmacists. And then for feasibility of mobile pharmacy and recovery housing, we see that there's a high willingness for both the patients to continue to use our mobile pharmacy in that capacity if it were to provide care in recovery housing. And then there's pharmacists who also feel that this will actually help participants go into the community to initiate care and then connecting the recovery housing residents to brick and mortar pharmacies that are stationary and always in the community. And so integrated findings of this mixed methods. First, there's an understanding of patient experiences and their preferences. And it shows that there's also a need for us actually to start thinking about designing pharmacy-based MOUD services. And then there's both patients and pharmacists' knowledge gap about recovery housing. And this is a known barrier to medication for opioid use access. And then stigma and related restrictive recovery housing residents does affect patients, but we that's seen about from pharmacists' perspective because of the limited awareness of what actually goes on in recovery housing. And then for the mobile pharmacy, there's an interest in having the mobile pharmacy partner with community pharmacists, and there's an interest in people with opioid use disorder to receive care from mobile pharmacies. And then for study limitations, this is a small sample. It's not generalizable. It's 49 people using a mobile pharmacy and clinic, and then it's 14 pharmacists in the Connecticut area. And so we're not really able to see any further examination between subgroups. And then participants are drawn from urban Connecticut area, so perceptions might differ elsewhere. And then although patients had varied exposure to MOUD, part of this is a study limitation in that as I'm reflecting on what I would have wanted to do this differently is to actually see if for people who had access to MOUD to study in depth what those experiences are and see how pharmacists can help. And so with that, I do have next steps that address some of the limitations. First, I'm currently received funding by the Society of Behavioral Medicine for the year 2025 to 2026 to develop training to actually build pharmacists' understanding of recovery housing. And I did not share earlier on, but part of what the pharmacists shared is how they want to know more about recovery housing and what they could learn about recovery housing and how that could be either CE credits or that could also be incorporated into pharmacy school curriculum. And then for this study, for the SBM, Society of Behavioral Medicine study, I'm interested in also using GeoAI to map proximity of pharmacies in Connecticut to recovery housing and to see if there's any overlap and what those relationships could look like. And then from the patient perspective, I'm seeking pilot funding to actually map pathways from housing entry, so from going into recovery housing to treatment initiation and continuity, and see if there are opportunities where pharmacists can actually support or improve this pathway. And then for next steps, I'm also thinking about system integration. This is hopefully a future idea, maybe funded by National Institute on Drug Abuse, where I would pharmacists to inform a model design where we can pilot a mobile pharmacy recovery housing integration where care will be continued or initiated for. And then so right now, our contribution to the literature, if we go back, I started by asking how do people in recovery housing access medication? I've learned a few things, but I've learned maybe too much that I need to take a step back and see. The main point is how is medication for opioid use accessed and how can pharmacy access that? And so now when I look up recovery housing and pharmacy, there's there's something there, and it's this presentation actually, and we presented it at the American Pharmacy Association conference earlier this year. So I'm hoping we continue to build if there are people that are interested in partnering or with pharmacy experiences that actually want to continue this deep exploration of pharmacy service for recovery housing. I will be excited to connect. And lastly, this is the first study ever actually to examine medication for opioid use in recovery housing from the perspective of use in areas of and also include pharmacist perspective. And for the mobile pharmacy study, we do have a manuscript that we published earlier this year that looks at the entire mobile pharmacy and clinic and our pilot findings for the individuals that we've been able to see. And this was published in the Open Forum for Infectious Diseases because we're focused on both people that are living or at risk for HIV and also have a history of substance use and need mobile pharmacies to go into their communities. And with that, I do want to thank National Institute of Drug Abuse and I-STARR, our funders for this project, my mentor, Dr. Sandra Springer, who started this mobile pharmacy initiative, my I-STARR mentor, Emmy Miracle, and then the entire Yale and Stride team, our mobile pharmacy team, and then to the patients partners, which includes recovery housing operators in Connecticut, and then just in totality, the communities that we serve. All right. Thank you.
Thank you so much, Dr. Tarfa. That was an amazing presentation. So at this point, we're going to open up for questions. And so members of the audience who have questions, you can raise your virtual hand or drop questions in the chat box. And I think, Amy, did we have some questions in the chat?
We did have some questions in the chat. First off, just Oddity, just amazing. So indeed, you are the first person to look at this. When we looked at MOUD and recovery housing, we're mostly talking to people who are currently in recovery housing. We're talking with recovery housing operators, and you've come at it from a completely different perspective. Catching people who have OUD, have access to MOUD in the community, and talking to them about recovery housing. I mean, that's brilliant. So we can learn about access to recovery housing. So we learned some really cool stuff there. And then, thinking about pharmacists and their role, not only in supporting MOUD, but they're supporting recovery housing. I mean, it's really brilliant. My hat is off to you. We have lots of folks who are wanting copies of your slides. So if you don't mind dropping your contact information in the chat, folks are wanting to be able to pore over them at their leisure, so we can make sure that they can get access to the slides if they have your contact information. We did have someone drop into the chat an interesting point about recovery housing or MOUD and pharmacists. And that was by Cheris Baz. Cheris, do you want to summarize your comment? I'm happy to read it to the group, but feel free to unmute yourself as well.
Thank you. My name is Karis, and I'm from Marin County, California. And I know this is a little bit off topic, but it relates to MOUD and the role of pharmacists, which is so important. We're doing a project with our Overdose Prevention Coalition to reduce stigma that patients experience when they go to the pharmacy to pick up these medications, which actually can be quite significant and decrease their incentive to continue for the recommended duration. And we're finding the pharmacists in charge often are supportive, but they won't let us come in and do the training and do the other parts of our program without approval from corporate. And we just have not figured out how to reach corporate. And the pharmacists are super busy, as you know, like they don't have a lot of time to dig into it on our behalf. So just any suggestions on how to better partner with pharmacists in retail pharmacies and or how to reach the leadership at the corporate or regional level would be greatly appreciated.
Thank you so much for sharing your experience, Cherish. And I would also share that some of the pharmacists that I reached out to talk with and interview did share that their corporate was not in support of being interviewed. So we share a similar experience. My recommendation has been to be able to partner with pharmacies, then go to corporate. It sounds almost like intuitive, but it's not necessarily, because we want to talk to pharmacists and not we're not talking to their leadership, but I think it might be helpful to reach out to their leadership. I've had partners at other institutions that have found their state pharmacy boards to be helpful, also to liaise some of these connections. So I think most states have community pharmacy associations. I think that would be a great place to start. Or second, institutions. Sometimes if there's a pharmacy school, we have our pharmacy students that graduate in their final year and are starting to practice as pharmacists before their after their board exam. So those could also be individuals that are more willing and have more time and are really also very invigorated with all the knowledge that they've learned in pharmacy school and are willing to partner. And one of my participants was that way, that I had 3 participants that had less than 1 year of practice, and they were very open and willing to communicate. So I hope that helps maybe talk to the pharmacy board, find pharmacy students and institutions around, and yeah, hopefully that might help.
Great. Other questions?
I have a question for Aditi. How much variation is there from state to state in what pharmacists can do and can't do? Yeah, I mean, do you have a sense of that? I mean, it sounds like you have a really wonderful opportunity to do neat things in Connecticut, but what if you're not in Connecticut?
Thank you. That's an excellent question, Amy. So what are some variations that we see in pharmacy practice? For medication for opioid use disorder, there are 10 states in the US, and I believe California, where you are, actually allows pharmacists to prescribe medication for opioid use under a collaborative practice agreement with clinicians or physicians specifically. So that's one that I know is the medication for opioid use prescription. And then, but on the state level, every state differs. So for pharmacy, just in general pharmacy training, there's the National Pharmacy Board exam that we pharmacists have to take. Then each state has its law exam, and each state differs on what pharmacists can do by law. One of the federal things that pharmacists have been pushing for is provider status, which is to be able to prescribe medications in general at the national level and not necessarily state specific.
Fabulous.
Yeah, awesome. Sue mentioned that Arizona also allows pharmacists to prescribe medication for opioid use. That's awesome.
And then there's Meena Subbaraman's question too. So it sounds like there's some variation in terms of MOUD, but what about just general advice beyond education around prescriptions? I mean, would they be able to talk to people about recovery housing? I mean, how would that role, or what would that role look like?
And excellent point, what that role would look like for pharmacists to be able to provide information about recovery housing. So I started my interest in pharmacy in the HIV world, and I've learned so much from there, where because of stigma around HIV, that in a lot of communities, I was in Wisconsin, we have pharmacies that are your typical retail pharmacy, but are known to provide and support people that were living with HIV. So there were almost your HIV pharmacy, but they did not do anything special beyond collaborating with AIDS organizations in the community, partnering with people with lived experiences. And so they have pamphlets in their pharmacy about food pantries. They had information about testing. They have information about starting medication, and they're able to talk to people that feel that they're at risk of living with HIV or are living with HIV and needs additional support. And so pharmacists play some of those roles depending on the communities that they're in and the need that they see. And when it comes to medication for opioid use, the stigma actually is still an issue with pharmacy practice. There's, I think it might have been Cherish that just mentioned it, that I feel like we have not made a lot of progress. And I would share one of the experiences that I had when I started my postdoc, when I was calling pharmacies around an area to see if they had medication for opioid use on their formulary. And then one of the pharmacists said, "We don't see those patients here." And that, it's stigmatizing, and there's a lot more. And so my sample of 14 pharmacists are interested in doing more, but there's more to be done. And I think in pharmacy education, so even when the pharmacists that I spoke with said they actually don't know what goes on in recovery housing, they want to know more about the people that they're supporting. They know that they do medication packaging, but they don't know what happens there, what kind of support. And so maybe there are opportunities for other people that are involved with the care for people with opioid use. So recovery housing operators, clinicians, people that lead peer support group to connect with pharmacists and provide education. And I see that in the small sample of pharmacists that I spoke with, there's interest in that area.
Great. And we have another question from Friedner Whitman.
Hello, everybody. Can you hear me all right?
Yes.
Yes.
Yeah, okay, good. Yeah, I'm asking this question on behalf of a colleague of mine in Los Angeles County who works in community level prevention planning, particularly around issues of availability, and also works with sober housing. And I told him about this upcoming seminar, and he had a question that he gets asked by people who are running sober housing in his areas in Los Angeles. And that is, if you know of any research or practice involving prescription of nicotine patches for people living in sober residences, and the extent to which there's been any study of that or look at that, and you might have any comments on issues related to prescription of nicotine patches for people living in recovery housing, how pharmacies might be involved, and whether there's been any work done on that.
Thank you, Friedner, for that important question. And your question is to see if there's any study on pharmacists providing nicotine patches to people in recovery housing, or just general about nicotine patches and recovery housing.
I guess both, but obviously you'd be better to ask about pharmacists' approaches to dealing with nicotine patches, and whether they would entertain requests from sober housing for prescriptions for residents of the houses and that sort of thing.
Yeah, thank you. That's so for pharmacy training, I think in my second year of pharmacy school, we're taught about nicotine patches, and I believe some states have prescribing authority for pharmacists to provide that. But beyond that, I do not know. And I will, the I-STARR is a mentored training, so I'm still learning about recovery housing. I can defer to Amy if you know specifically if there is interest, but I do think, Fridna, that you've added maybe something that when we continue to look at recovery housing and pharmacy, that's a really excellent and important pathway, because I know that pharmacists have contributed a lot to nicotine patches prescription and access. So Amy, about general.
No, I think that's an exciting topic, and there's someone actually here at the Alcohol Research Group at ARG who is very interested in that, particularly tobacco cessation and recovery housing in particular. So I think that we have a webinar coming up that's scheduled specifically on that topic.
That's right. So in May, you're going to have tobacco use and recovery housing.
Exactly. So please stay tuned.
Yeah.
Okay, thank you. Right.
And Friedner, I know that in San Francisco, the pharmacists here do provide both counseling and nicotine patches to people who are in recovery for substance use disorders. So there is an effort to try to disseminate best practices for dealing with nicotine addiction.
That's in San Francisco?
Yes.
So the San Francisco County DPH would be a place to go for that?
That's right.
Okay. Thank you.
Maybe if you can share your email in the chat, I can also look more and get back to you on that, and get back to you and your friend on that.
Okay, let me put that in the chat here then.
Well, this has been great. So I hate to cut off the discussion, but I want to inform you about some upcoming events that are being sponsored by the I-STARR project. So Next month, we will be hosting a webinar that will feature Dr. Kelly Knight. And the title of her presentation is Overdose Vulnerability and Service Needs Among People Experiencing Homelessness. And in February, we're going to be hearing from Alexander Sikora and Dr. Ted Babak, and they will be presenting on the role of social networks in supporting residents taking MOUD in recovery housing settings. So just to remind you, the I-STARR webinars are held on the third Tuesday of the month from 11 to 12 for those on the West Coast, which is 2 to 3 for those on the East Coast. And you can also register for any or all of the webinars that we have scheduled on the I-STARR website. And you can also stay connected with the I-STARR project through our social media accounts, which are listed on the slide. And while you're on the I-STARR website, you may also see information about the I-STARR training series. So we have developed a training series that consists of 12 webinars with separate training topics for recovery housing operators and providers, as well as those interested in conducting research on recovery residences. So those who participate in all the 12 webinars in the training series receive a certificate of completion and will be provided the option of being identified on the I-STARR website as someone who's completed this training. So at this point, because our live webinar series has ended, we can only track completion of the webinars if you register for the series and then view the webinars on the I-STARR Learning Management System on the website. So if you have any questions about the training series or how to complete it, please reach out to us. And so we're running out of time, but I want to again thank our wonderful presenter, Aditi Tarfa, for an amazing webinar, and everyone who's in attendance today for their time and attention. And we hope to see you back here again on Tuesday, January 20th. And so enjoy the rest of the day and the intervening month. Happy holidays, everyone.